Today I will discuss with you vitamin B6, its active form, and the effect of B6 on concurrently given drugs. Dear friends and students, the purpose of this presentation is to recapitulate the role of B6 in health and disease, to understand the interaction of B6 with other drugs when B6 is in concurrently with them, to prepare students for VOC assessment, and to enable the prescribers for rational use of vitamin B6. The biologically active form of the vitamin B6 is pyridoxine, but more importantly pyridoxal 5-phosphate, which is called as PLP, and this PLP acts as a cofactor for several enzymes, actually more than 100 enzymes, and particularly carboxylases and transaminases in metabolic reactions, and therefore vitamin B6 influences metabolism of proteins, lipids, carbohydrates, and also affects synthesis of several hormones. B6 is given orally, mostly in the form of tablet or syrups in children. It is a part of the multivitamin syrups, but when given orally, it is readily absorbed by diffusion, is quickly distributed in circulation, and a very short stay in the blood, and 80 to 90% of the B6 is found in muscles where it is stored, and about 172 milligram of the B6 is found in the muscle stores. Its half-life there is 25 to 33 days. So tissue half-life is longer than blood half-life. It is metabolically activated by oxidation and subsequently phosphorylation to pyridoxal 5-phosphate, which is biologically active. It is excreted in urine as pyridoxic acid by metabolism, and majority of B6 is complex with muscle glycogen, phosphorylase, and physiological requirements vary from age to age. Usually adults would require 1 to 2 milligram, children require little more, chronic alcoholics require 2.5 milligram, and those who are on parenteral nutrition or on high diet should be given 5 to 6 milligram. The drug is available in various dosage form, alone or along with other drugs, but here I will only discuss the single dose formulations. A tablet containing 10, 20 milligram, 40 milligram, and a long acting tablet containing 100 milligram is available in India, and it is this combination of this drug is used for the treatment various disorders in varying doses. Injectable B6 contains 100 milligram in 2 ml alone or along with usually vitamin B12, methylcobalamin, and nicotinamide as 100 milligram. Oral dose usual for nausea vomiting in pregnancy is 10 to 25 milligram. For prevention of isoniazid toxicity, the dose can vary from 10 milligram, which is co-formulated with isoniazid, to 100 milligram in a day. 20 milligram OD has also been given as once daily preparation for nausea and vomiting prevention of early pregnancy, and in the event of pyridoxine deficiency it should be given initially parenterally, later on it is given in lower doses orally. What are the indications of vitamin B6? There are a lot of indications where there is certain or uncertain value of vitamin B6. Some of I will discuss as points only, the others I will discuss in details. Premenstrual syndrome, where a dose varies from 50 mg to 200 mg, although when 50 mg once daily is considered to be sufficient, can be given cyclically or continuously. In the same way, Cyclic mastalgia in females would also require 50 to 100 mg twice daily for 1 to 2 months. For early pregnancy, for nausea and vomiting, I will discuss in detail. It is also given for alcohol-induced peripheral neuropathy for the treatment, and endogenous depression when it occurs due to contraceptive use, and also peripheral neuritis occurring due to penicillamine. Pyridoxine responsive anemias can respond to pyridoxine. It is also given in the treatment of homocystinuria, in sideroblastic anemia, which may be due to pyridoxine deficiency or without, or due to isoniazid pyrazinamide. It also requires vitamin B6. For suppression of lactation in females, to decrease prolactin secretion, pyridoxine is given. We will discuss in detail. For infantile convulsions, hyperoxaluria, and high doses have been tried in carpal tunnel syndrome, schizophrenia, diabetic neuropathy, and autism, but the results are variable because carefully controlled trials are lacking. The role of B12 in nausea, vomiting, early pregnancy. B12 has been used to prevent the early pregnancy manifestations, nausea, vomiting, since 1940, and alone B6 improves mild to moderate nausea but has very little effect on vomiting. American College of Gynecologists recommends use of B6 as the first line drug in hyperemesis as a category A status. Its anti-emetic form of vitamin B6 could be the biologically active cofactor form, that is pyridoxal 5-phoxyl. Recommended dose is 10 to 20 mg orally every 6 to 8 hours, with a maximum treatment dose suggested for individual is 200 mg per day. B6 alone, as I told you earlier, is not very effective in controlling vomiting, and therefore there is a rational combination of doxylamine, which is an antihistaminic, with B6, which is found to be more effective in controlling not only nausea but also vomiting. A combination contains 10 mg each, 20 mg each, or a long-acting formulation of 20 mg B6 with doxylamine 20 mg, and where it is commonly used for longer acting effect, particularly at night. Doxylamine is antihistaminic, which inhibits the histamine effect on H1 receptors, indirectly affects the vestibular system, and also decreases stimulation of vomiting center. Now, D-Penicillamine and B6 interaction must be understood. D-Penicillamine is a chelating agent which is often used to chelate copper and in the treatment of rheumatoid arthritis. Now this has a multiple effect on B6, and that is anti-vitamin B6 activity of D-Penicillamine is explained by chelation. That is a chelate formation, complex formation between D-Penicillamine, pyridoxal complex, and copper. It also forms a thiazolidine compound with active form PLP, which is biologically inactive. D-Penicillamine also increases urinary B6 excretion and lowers vitamin B6 levels extensively in serum in experimental animals, and penicillamine can produce a deficiency of vitamin B6 by inhibiting phospholipase synthesis. The classical interaction between vitamin B6 and levodopa is known to occur. There was a time when levodopa was given alone in the treatment of Parkinsonism. Now, the pyridoxal phosphate is a cofactor for L-amino decarboxylase enzyme that is involved in conversion of dopa into dopamine. Dopamine doesn't enter brain, so levodopa is given, that enters brain, and in this brain the central L-amino decarboxylase enzyme converts it into active dopamine in basal ganglia. However, when B6 is given, this conversion occurs in peripheral tissue and blood, and more of the dopamine is formed in the peripheral tissues causing nausea, tachycardia and changes in the blood pressure. Less dopa reaches the brain, so less is converted into active dopamine in the basal ganglion. B6 supplementation above 5 to 10 milligrams will therefore reduce the effectiveness of levodopa when given alone in the treatment of Parkinsonism. Fortunately, levodopa is currently not given alone but is given along with a peripheral decarboxylase inhibitor, carbidopa, and this combination of levodopa-carbidopa would not show B6 antagonism. However, it is important that B6 could be taken in disguised form. Patients come for weakness, they already suffer from Parkinsonism, and a multivitamin or polyvitamin tablets are given which may contain B6. Therefore, that could antagonize the effect of levodopa. Now, INH and B6, the functional pyridoxine deficiency is the likely mechanism of INH-induced neurotoxicity, particularly peripheral neuropathy, and multiple effects can be seen. Inhibition of activation of B6 into the cofactor active form by inhibiting pyridoxal phosphokinase by the INH and its metabolites. The second is INH inhibits pyridoxal phosphokinase itself, which results in deficiency and neuropathy. Next is INH binds to PLP to form a complex hydrazone, and that depletes neuronal pyridoxal phosphate. Therefore, it interferes with the neuronal function, and it also reduces brain GABA synthesis, and that explains the central excitotoxicity of isoniazid in high doses. Simultaneously, there is increased excretion of B6 as hydrazone complex. Therefore, INH therapy usually requires a preventive dose of 10 to 15 milligram vitamin B6 to avoid occurrence of neuropathy. However, when neuropathy occurs, then very high doses of the isoniazid up to 1 to 5 milligrams have been given to antagonize the CNS and peripheral neuropathic. Oral contraceptive use in vitamin B6. Oral contraceptives cause PLP deficiency because the pyridoxine phosphate gets redistributed into tissue. The estrogen component is the main culprit, and that affects or induces several PLP dependent enzymes where PLP acts as a cofactor, for example oxygenase. Therefore, it increases its requirement physiologically. One may require supplementation with B6 up to 5 milligram per day. Oral contraceptives also increase CRP level, which is an inflammatory marker. The level of CRP is inversely related to the concentration of pyridoxal phosphate, and therefore probably this could explain why if CRP increases with OCs, the pyridoxal phosphate would decrease. But nowadays, with lower estrogen containing oral contraceptives, this adverse interaction is less often seen. Estrogens alter B6 metabolism, and therefore vitamin B6 20 mg twice daily may be effective in depression caused by oral contraceptive use in certain females. Infantile convulsions, pyridoxine responsive anemia, and less often used hydrolysine induced peripheral neuropathy are other uncommon uses of vitamin B6. Now, pyridoxine has been used since years for the suppression of lactation when the child doesn't survive and mother wants that milk suppression should be there. Mechanism involved is pyridoxine acts as a coenzyme that promotes the conversion of to dopamine in the brain. Dopamine itself is considered to be prolactin inhibitory on the anterior pituitary cells which secrete prolactin. Increase in dopamine formation in hypothalamic neurons and their major dendrites that results in inhibition of pituitary prolactin secretion, therefore decrease in milk formation in the mammary glands. For this, a higher dose is given, 100 to 200 mg 3 times daily for 6 days. Several systemic reviews of carefully controlled RCTs show that the overall clear efficacy is not there. Now, another current use of pyridoxine is in the treatment of urolithiasis. B6 deficiency results in increased production and excretion of oxalates. Supplementation with B6 reduces oxalate excretion in urine. Hence, B6 as 10 mg is tried to reduce the risk of formation of recurrent calcium oxalate stones alone. It is also combined with magnesium citrate 200 mg, and this combination has been tried for many months to years to reduce the stone formation in susceptible individuals who have history of recurrent urolithiasis. Proposed mechanism is that the biologically active form of pyridoxine is required as a cofactor for enzyme AGT. This enzyme converts glyoxylate to glycine. When there is B6 deficiency, AGT activity is reduced and thus more of the glyoxylate is diverted and converted into oxalate by lactic dehydrogenase enzyme. Therefore, pyridoxine may be very useful in those who have recurrent stone in the kidneys. Magnesium co-therapy as magnesium citrate has multiple additive effects. Magnesium keeps calcium in solution, thus prevents deposition. Magnesium reduces dietary oxalate absorption from gut, and magnesium citrate produces alkaline urine, so calcium oxalate and uric acid remains dissolved, so more is excreted without formation of focus or nidation for renal. Various dosage forms available for urolithiasis are liquid 5 ml contains potassium citrate, magnesium citrate and vitamin B6 20 mg. Recommended dose is 15 milliliters 2 times a day in 1 glass full of water after meals for many days, many months. Or one can take tablet which contains potassium magnesium citrate with pyridoxine 15 mg 2 tablets twice daily after meals. Now, when B6 is given in high doses, toxicity is likely to occur, and B6 toxicity is also characterized by neuropathy. Ingestion of more than 2 grams is known to cause peripheral neuropathy, sensory neuropathy with sensory ataxia, photosensitivity and dermatitis may also occur. Nerve biopsy shows axonal loss and loss of dorsal loose ganglion. Therefore, to summarize, there are many conditions where there is a functional B6 deficiency, and drugs are important reason for functional B6 deficiency or increased requirement. Apart from L-dopa, penicillamine, oral contraceptives, other agents are L-tretamine, which is alkylating agent, and B6 if given with L-tretamine, it will reduce its therapeutic anti-cancer activity. Phosphenytoin is an anticonvulsant, and high dose may decrease phenytoin levels also. High dose of B6 will decrease phenytoin levels. Amiodarone is antiarrhythmic drug, long-acting antimetabolic drug, and B6 may enhance phototoxicity due to amiodarone. So one should avoid B6 in excess of 10 mg per day. Theophylline may react with the pyridoxal phosphate, leading to low plasma level of the coenzyme. So there is an increased theophylline induced seizures. And other drugs where such interaction could occur is carbamazepine, ethinomide, cycloserine and valproic acid. They all may require they increase the requirement of vitamin B6. Thank you all for this. Please.